Psychiatry, Pathology, mood disorders. Schizophrenia disorders is what we're going to start off with. So schizophrenia and its associated disorders are very high yield on the exam. And one of the key takeaways that I want you guys to know is essentially the days in which something becomes schizophrenia, like the timeline in which something becomes schizophrenia compared to schizophreniform, compared to brief psychotic disorder, okay? Because these are all very associated with one another and it can get confusing, okay? So the hard rule, which I will repeat later on, but I just want to make it clear at the beginning of the video, from 1 day to 1 month, if you have the episodes, it's known as brief psychotic disorder. From 1 month to 6 months, if you have the episodes, it's schizophreniform. And then greater than 6 months, it's known as schizophrenia. All right? Very key in understanding the diagnosis is those timelines. So 1 day to 1 month is brief psychotic disorder. 1 month to 6 months is schizophreniform. And 6 months or greater is schizophrenia. All right, so now let's discuss what you could potentially see in a patient with schizophrenia. So schizophrenia, once again, it's like a common chronic illness, okay? Chronic illness, okay? And what happens is that you get two types of symptoms. You have positive symptoms and negative symptoms. Positive symptoms just means that it's adding an additional thing, okay? There's an additional symptom occurring. Negative symptoms is something that's taken away from the person, okay? So for example, positive symptoms would be hallucinations, delusions, okay? Unusual thought processes, disorganized speech, bizarre behavior, okay? So you're going to see, in addition to their normal behavior, something's added, like a hallucination or delusion. For negative symptoms, it's opposite. You'll see something taken away from their normal behavior. So they'll become like flat affect or blunted affect, meaning they just like are numb to everything. They have like no emotion. They have apathy, anhedonia, all right? They have social withdrawal. Those are your negative symptoms, all right? Now, the diagnostic criteria, it requires greater than 2 of the following active symptoms, including 1 from symptoms of delusions, hallucinations, or disorganized speech, okay? So, of the 5, you have delusions, hallucinations, which are often auditory, disorganized speech, disorganized or catatonic behavior, and negative symptoms, okay? And you have to have 2 of the following, and at least 1 of those must be delusions, hallucinations, or disorganized speech, okay? Very, very important. Now, some things that you could take away is that these patients present to you sometimes as like dirty. Okay, they'll say that the patient looks dirty. Okay, dirty patients. All right, that's going to give you a hint that it could be a schizophrenia type of disorder. All right. Now, the reason behind this schizophrenia is because it's associated with altered dopaminergic activity. All right, and we already discussed what positive symptoms and negative symptoms truly mean. Positive symptoms of schizophrenia are caused by increased activity of dopamine in the mesolimbic pathway, right? So increased activity of dopamine in the mesolimbic pathway is going to give us our positive symptoms in schizophrenia. Now, on the other hand, when we're talking about negative symptoms, it's going to be decreased activity of dopamine in the mesocortical pathway, okay? So these are the 2 main takeaways that they could definitely potentially ask you about. So keep that in the back of your mind. All right, when we're talking about increase in mesolimbic pathway, that's going to be our positive symptoms. Decrease in mesocortical pathway, that's going to be our negative symptoms. All right. Now, just a little bit more about schizophrenia. The patients with positive symptoms only have a better prognosis. So whenever a patient comes and presents with negative symptoms, it's scarier. They have a worse prognosis. So if it's only positive symptoms, we can help treat them a little better. But if it's positive and negative, then we have a more difficult time, okay? And the negative symptoms, once again, it's like a flat affect. They have decreased facial expressions, right? It's just things that are taken away out of the patient, all right? Now, you treat them with atypical antipsychotics like risperidone is the first line. It's something that they want you to know, all right? Now, negative symptoms, once again, as we discussed, leads to a worse prognosis because they persist after treatment most of the time. Right, so you're going to have resolution of positive symptoms when you give them atypical antipsychotics like risperidone, but it's very hard to treat those negative symptoms. All right. Now, so schizophrenia, to be diagnosed with it has to be lasting greater than 6 months. All right. So don't get too bogged down with the diagnostic criteria of requiring greater than 2. If you see a patient that essentially has the signs and symptoms of schizophrenia that you know just from common knowledge that's lasting for greater than 6 months, and the patient's also dirty. Remember that dirty trigger word. If the patient comes dirty and they're having these weird delusions, hallucinations, and disorganized speech, you know those signs and symptoms without actually trying to meet that criteria. Okay, so I never tried to meet the diagnostic criteria and memorized it. I just looked at the patient as is and said to myself, okay, does this fit a normal picture of schizophrenia? All right. Now, I want to kind of describe what delusions, disorganized thought, and speech looks like in hallucination. So just real quick to describe them, give them a definition. Delusions are kind of false, fixated beliefs that persist even though there's contrary evidence towards the opposite. Okay, so for an example, if someone were to say, oh my gosh, the government is spying on me, okay, and if you could provide them evidence that the government's not spying on them, you show them around the house, there's no one recording them, there's no video cameras present, they'll be like, no, there's video cameras present in my room, they're recording me, the government's spying on me. Well, once again, that should tell you that that's a delusion, because you're showing them that there's no video cameras in your room and they still believe in it. Next is disorganized thought and speech. It's just the same thing, okay? It's as it's noted, okay? It's like a word salad, all right? People just speak incoherently. And then the last one's hallucinations. Hallucinations come in all shapes and sizes. You could have auditory, which is the most common type in schizophrenia. And then you could also have like visual, which is usually seen in like neurological diseases or drug intoxication, as well as delirium. You can have tactile, which is usually cocaine crawlies, they call them. Olfactory is associated with aura of the temporal lobe epilepsy. Remember, we discussed the burning rubber smell before they had a seizure. And then there's two types of hallucinations that's associated with narcolepsy. One's associated with going to sleep, one's associated with waking up. But they're both associated with the pathology of narcolepsy. And it's hypnagogic and hypnopompic. Hypnagogic is hallucinations going to sleep, so gogic, going to sleep. Hypnopompic is when you're pumped up and waking up from sleep. Okay, those are hallucinations at different times of the day. While going to sleep or waking up from sleep, both associated with narcolepsy. All right, I just thought it was important to kind of define those symptoms that you're going to see in a lot of these mood disorders. But okay, that's schizophrenia. Now let's move on to schizoaffective disorder. So actually, before we move on to schizoaffective disorder, I just want to reiterate, schizophrenia is greater than 6 months. Brief psychotic disorder is going to be between 1 day and 1 month. Okay, very simple symptoms. It's like greater than or equal to one positive symptom. Okay, it's going to be like usually in a stressful time period. And then schizophreniform is going to be lasting 1 to 6 months. Okay, with very similar symptoms. All right, I want you to know that brief psychotic disorder is less than a month. Schizophreniform is 1 month to 6 months, and greater than 6 months is schizophrenia. You have to know that. All right, now moving on to schizoaffective disorder. Schizoaffective disorder is, the way that we remembered it, is schizoaffective disorder. So you have schizophrenia and you add a mood disorder. Okay, very straightforward. That's how we remembered it. Schizoaffective disorder is schizoaffective disorder. So it's schizophrenia and you add some type of mood disorder, usually like major depressive disorder or bipolar disorder. Okay, so one thing that's key though is that the patient must have greater than 2 weeks of the psychotic symptoms without a manic or depressive episode. So you have to have greater than 2 weeks of the patient experiencing schizophrenia type symptoms without any type of depression or mania. Okay, so the psychosis is what they call it, the schizophrenia type symptoms. Psychosis must occur without major mood episodes for greater than 2 weeks for it to be schizoaffective or schizoaffective disorder. All right, so that's kind of the main takeaway. Next is delusional disorder. Delusional disorder is greater than one delusion or equal to one. It could be just one delusion that lasts for more than 1 month. Okay, so you have to remember that it lasts for more than 1 month. All right, and once again, what's a delusion? We already discussed it. It's a false idea or belief, and no one will believe you. Like, they won't believe you even if you show them evidence that their belief is incorrect, that their delusion is incorrect. Okay, but the key takeaway for delusional disorder is that everything else is normal functioning. They have normal daily functioning capacity. So they go to work, they're completely fine. They could go out with friends and interact, whatever. But right when they get triggered, okay? Right when they get triggered, they will be like, oh my gosh, this is occurring, okay? So right when they come home, they'll be like, oh my gosh, have you checked the camera? Did you check outside to see if the cameras are still recording us? And then you'd look at your significant other and be like, what are you talking about? There's no cameras outside. We've already looked. They still don't believe it. No, there's cameras outside. I promise you, they're recording us. So even if you provide them contrary information, they still believe in it. Okay, but they're normal functioning. That's very key to delusional disorders. They will go to work and be normal functioning patient, like people in society. All right. Next is kind of defining manic episodes, because the rest of the mood disorders are going to be associated with some type of manic episode. So first, if you see a patient speaking in a pressured type speech, if they say pressured speech, then you know that they're trying to hint at a patient in some type of manic episode, all right? And now manic episodes are going to be defined as just like a patient that has increased energy, increased activity. They have an irritable mood. They're staying up really, really late, and they're not going to sleep. They're doing these crazy things. They have a crazy flight of ideas, okay? So the way that they remember this is dig fast. D, distractibility. I is impulsivity. G is grandiosity. F is flight of ideas. A is agitation and activity. S is for decreased sleep. And T is for talkativeness or pressured speech. Okay, so I want you to take into account all of these different types of symptoms, but I don't want you to memorize them because once again, these are very simple disorders that you can just like notice within the question stem that they're trying to hit at a manic episode. It's not something that you're like, oh, they meet this criteria for these symptoms. No, it's just something that you take into account for a patient. But if you want to know this criteria, you have marked functional impairment with greater or equal to 3 of the following that I just said of the dig fast. But it has to last for more than a week for it to be a manic episode. And that's key. All right. So once again, if you've noticed for all these mood disorders, I've given you timelines and they're very key. All right. And we're going to run through the timelines at the end of this video because it's very high yield. But 1 week for manic episodes. It has to last for greater than or equal to 1 week for it to be a manic episode. So now let's get into our disorders. So first we have bipolar 1. Bipolar 1, all that it is that it's greater than or equal to 1 manic episode. Okay. Depressive episodes are not needed. Okay, so a depressive episode is not needed. If you just have 1 manic episode that lasts greater than 1 week, right? Because it has to last greater than 1 week for it to be defined as a manic episode. If you have 1 manic episode or greater than 1, but 1 is fine. If you have that, it's bipolar 1 disorder. Okay, very straightforward. You do not need any depressive episode. Okay, now for bipolar 2, it's a little different. It requires a hypomanic and a depressive episode to be diagnosed. So you might be asking, what's a hypomanic episode? Well, it's very, very easy and straightforward, okay? It's very similar to a manic episode, right? But it's not severe enough to cause like marked impairment, okay? So they have like normal social or occupational functioning. They can go to their work, they're very social still, okay? And there's no psychotic features associated, right? It lasts greater than 4 consecutive days. All right, remember that manic episodes last greater than a week. This lasts greater than 4 consecutive days for it to be hypomanic. But remember, it doesn't cause like impairment. All right. And so it's like kind of a lesser version of manic episode. So if you see like a lesser version of manic episode that lasts like less than 7 days but greater than 4 days, you know that you're in a hypomanic state. And so you should ask the patient about a previous depressive episode because it could be bipolar 2 disorder. All right. So bipolar 2 has to have a hypomanic episode, which is less severe, right, to the manic episode. It does not involve psychosis, and it causes lesser function impairment. Okay, so it compared to an actual manic episode, you have more functionality. All right, in a hypomanic episode, but you have to also meet criteria for a depressive episode. So bipolar 1, you have to have a full manic episode. That's it. If you have that, you meet criteria. Bipolar 2, you have to have a hypomanic episode and a depressive episode. Okay, and that meets bipolar 2 criteria. All right. Next is MDD, major depressive disorder. Major depressive disorder, it's just essentially depression. And now it's recurrent episodes that last greater than or equal to 2 weeks. What matters more for me is the diagnostic symptoms. They say you have to have at least 5 out of the 9 diagnostic symptoms, which is SIGI caps. Okay. 1, sleep disturbances. 2, decreased interest in like activities that they used to like to do, which is anhedonia. 3, they have guilt or feeling of worthlessness. 4, decreased energy. 5, decreased concentration. 6, appetite or weight changes. It could be increased appetite and weight changes or decreased appetite and weight changes. I think I'm on 7 or 8, psychomotor retardation or agitation. So they might have some psychomotor abnormalities. And lastly, suicidal ideation. All right. Now, this is kind of a common thing for all these psych pathologies. I personally never sat there and counted each one, but my buddies swore by it. They're like, I'm going to count each one of their symptoms that they list because they list a lot of symptoms. If you could count 5, boom, you have your answer for MDD. And there's no other symptoms like manic episodes or anything like that, right? So people like, some of my friends, they like to count that. They like just to count them, the symptoms. But for me, if you see a patient and they're presenting with like your normal symptoms of what depression looks like, then like you can get it, right? You know that they're talking specifically about MDD. One of the key things I always look for is a decrease in interest in pleasurable activities that they used to like doing prior. I see, and that's known as anhedonia. I see anhedonia a lot in question stems. All right. Now, one major thing that they want you to know is that you must ask the patient if they've had a previous manic episode. Okay. Because if they have had a previous manic episode and they're now experiencing MDD, then that puts them at risk for bipolar 2 disorder, right? Okay. Or they could be bipolar 1, right? Because it's plus or minus a depressive episode. But it puts them at risk for bipolar. So you have to ask them about a previous psychotic episode or previous manic episode. All right. And the reason behind that is because if someone comes in with MDD and you give them treatment, the number one first line treatment is CBT, cognitive behavioral therapy, as well as SSRIs. But if you give a patient an SSRI that has bipolar and you think that you're just treating their MDD, it can trigger a manic episode. So you have to ask the patient if they've had a previous manic episode if they present to you with MDD, because you cannot give them an SSRI if that's the case. You have to treat them for actually bipolar disorder, which is going to be like lithium or valproic acid or carbamazepine, all right? Those are the 3 most high yield things, but lithium is the highest yield or first line treatment for bipolar disorder, okay? Next is going to be persistent depressive disorder. So persistent depressive disorder is going to be, it's like a milder version of MDD. Okay, so you don't have that many symptoms. You have 2 depressive symptoms, but it lasts for a really long time. It lasts greater than 2 years. Okay, so it's less severe but longer lasting is persistent depressive disorder. That's all you need to really take away from it. Major depressive disorder, remember, you need 5 diagnostic criteria for greater than 2 weeks. Persistent depressive disorder is going to need greater than 2 depressive symptoms that last greater than 2 years. Okay, so less severe but longer lasting. Okay, now MDD with seasonal pattern. This is just something I like to bring up because I feel like a lot of people in Ohio struggle with this because of the changes in winter to summer. Whenever they it's just based off of the seasons. So whenever it's winter outside or cold outside and it's dark earlier in the day, patients can present with some types of symptoms of MDD, but it has to last for like greater than 2 consecutive years during that time period. Once again, not as high yield, but I think that, it's important because treatment includes light therapy. So that's why if you see in the Neomed library, they put a bunch of lights because it helps for MDD with seasonal pattern, or seasonal depression is what we call it, kind of just in the normal world. All right. Next is depression with atypical features. Depression with atypical features is it's essentially based off of your mood. Okay. So at times you could be depressed, and then at other random times, everything's fun. You're on vacation and you're with friends, so you're not really that depressed anymore. But then other times, you kind of get in your feels and you can become depressed. That's depression with atypical features, okay? This is the most common type of depression. And treatment's the same, CBT and SSRI, all right? Cognitive behavioral therapy and SSRIs are really, really helpful for a lot of problems with psychiatry. Now, before we end the video on mood disorders, I want to run through just really quickly what you should expect on the timetable. What is the timeline like for each of the diagnostic criteria for mood disorders? Okay, so let's start with the psychotic disorders. If you have brief psychotic disorder, it's less than a month. If you have schizophreniform, it's 1 to 6 months. If you have schizophrenia, it's greater than 6 months. I cannot tell you how important this aspect of it is. Okay, they're going to ask about a lot of different timetables, but the most high yield timetables are psychotic disorders. So keep that in the back of your mind. It's very, very high yield. All right. Next, it's schizoaffective. All right. So this is what schizoaffective. So you have schizophrenia with a mood disorder like MDD or bipolar. But remember, you have to have greater than 2 weeks of psychosis without major mood episodes. All right. Delusional disorder has to be longer or greater than a month. Okay. Manic episodes are going to be lasting greater than a week for it to be a manic episode. Hypomanic episode is going to be greater than 4 consecutive days or equal to 4 consecutive days. All right. Very high yield to know all these. Major depressive disorder is going to be lasting greater than 2 weeks, whereas persistent depressive disorder is going to be lasting greater than 2 years. All right. So that's all for the timetable that I think is like highest yield. But just break everything down for yourself. If you want to memorize the diagnostic criteria, go right ahead. But I'm telling you, as you do more questions, you'll be able to pick it out much easier, okay?